Live streaming is on.
Okay, so we've started live streaming, and let's see your options. The following suggest myocardial infarction on ECG, and your options are A, ST segment elevation, B, pathological Q waves, C, bundle branch block pattern, D, pre-excitation pattern on ECG, E, flutter waves. Okay, so most of you are choosing A. Tim, I no forgive. Okay, so I think the essence of this is for you to also try to determine which other conditions could explain these other things, these other options. You may be correct. Of course, you are correct about the obviously A is very obvious. At least this is one of the simple ones. Like I said, your exam strategy should always be to simple ones first. Go around, pick all the simple. One just joined us. AB. AB. Okay. You're welcome. So, flutter waves should be seen in what kind of cardiac condition? Okay, Annie B, you're welcome. So, flutter waves will be seen in atrial flutter, right? That's the kind of sawtooth appearance. Then bundle branch block pattern on ECG. Anyway, you'll be seeing widened QRS complex and a lot of other things that will suggest whether it is right bundle branch or whether it's left bundle branch pattern. Then pre-excitation pattern on ECG. An example of pre-excitation is Wolff-Parkinson-White. Then the second one, Lennon-Ganon-Levin syndrome. So pre-excitation syndrome can show up on ECG. It's presence of PR interval. That's the first thing you will see. Shortened PR interval. Then presence of delta waves. Then widened QRS complex. Okay, so that's that about Q wave. Can also be seen on myocardial. Can also be seen, but usually an old myocardial infarction. You can also see pathological Q waves. All right, so let's move along. Let me get the next question. Are you asking a question, Temi? You said atrial flutter and ventricular fibrillation. That you will see flutter waves. No. Flutter waves are for atrial flutter, not for ventricular fibrillation. In ventricular fibrillation, there will be no QRS complex, no P waves. You understand? So that's how you differentiate them. I'm back. Sorry for the little delay in transmission. Um, I was logged out. So we are still live streaming. Yeah, I know the audio was off. I was having some challenges. Anyway, atrial flutter and ventricular fib. Okay, I've answered you. So let's ride on. Annie B, are you having any challenges? There's a button. I think this is the first time you are joining us. So when you turn your look at your phone on the left lower corner, there's a button right there that you can click. When you click that button, you can actually make comments. And I'm also seeing that your network is very poor. It's showing red. So you have a very poor network. But I think you'll still be able to manage with us. Yeah. I see him. Lele, it's coming up now. Now it's yellow. So enjoy small. Let me get the next question. Which network are you using? Hope is not everywhere you go. I know. It's everywhere you go. Big man, big trouble. And get the next question. Um, Hold on. I'm still trying to get the question. So let's see what this next question will be about. Um, okay. So this next question is asking about, it's going to anatomy now. It's going to the brain, straight to the brain. And it's asking about the floor of the fourth ventricle. So someone told me today that he thought that West Africa was easier. I was like, okay. Okay, so here we come. Here we come. That's the question. It says floor of the fourth ventricle, except A, hypoglossal nucleus is medial to the vagal nucleus. B, stria medullaris contains auditory fibers. C, superior medullary velum forms the upper border. Damage of the fourth ventricle may lead to death of the vital structures located within. So let me see your answers. We are seeing your answers. think this is one of those questions where you don't have any idea at all. It will likely be. Okay, let me see whether I can find any video that relates to it. Fourth ventricles. Anyway, in the ventricles of the brain are like spaces, anatomical spaces that are involved in transmitting CSF. They are like space and bathe the surfaces of the brain tissues, you know. So there is the first ventricle, aka lateral ventricles, and there is the ventricle, because lateral ventricles like 1 and 2, you know, when you say something is lateral, it means it's like a twin. There are two, one on the left, one on the right. So 1, 2. Then there's a third ventricle, which is between the lateral ventricles and the fourth ventricle, then followed by a fourth ventricle, okay, which is supposed to be connecting the third ventricle, you know, being in the space between the third ventricle and the central canal of the spinal cord. Okay. So let me see. I think I found something that may be helpful to you. Some of you chose A, some of you chose B, but I want this to be helpful to you so that tomorrow, if you see a question that relates to that, you'll be able to answer it without flinching. They may not give you the exact question, but it can still give you something that relates to that.
So in this video, I'm going to talk about the structures of the fourth ventricle in the brain. And I'm also going to cover the macroscopic structures
Some of you
and the
that have
cranial
some
nuclei of the
special update materials for
now,
2020.
just for orientation's sake,
You
here
can
you see
push it
the
along,
pons, and here you see the
send them
medulla
to me.
oblongata and the
Then
cerebellum. These three
let's see
are formed
that
by
there's a way
the
we can
rhombencephalon
that there are
during
any
development.
update materials
And up
there
here
that
you see the
relates to.
mesencephalon. So in this video, I'm going to talk about the structures of the fourth ventricle in the brain. And I'm also going to cover the macroscopic structures and the cranial nuclei of the rhomboid fossa. So now, just for orientation's sake, here you see the pons, and here you see the medulla oblongata and the cerebellum. These three are formed by the rhombencephalon during development. And up here you see the mesencephalon, or the midbrain, and the diencephalon and telencephalons formed by the prosencephalon. So now let's start with the fourth ventricle, or the ventriculus quartus in Latin. So the fourth cavity, or the ventricle, you can use both, it's the same. The fourth cavity is the cavity of rhombencephalon, which is the pons, the medulla oblongata, cerebellum. It's located right about here. So if you look at it in a more detailed view, you will see that it looks like this. And now, just for orientation's sake again, here you see the cerebellum and the pons and the medulla oblongata, and here you see the midbrain, and down here the spinal cord. So this is the
and so that all the names of persons can move to one side, and then you will have a wider screen. Okay.
Fourth ventricle. So as you see, it has a tent shape or a pyramid shape. It depends on your imagination. To me, it looks more like a tent, because here you walk in and you can chill in your tent. So the roof of your tent is right here. The roof of your tent is called the tegmen ventriculi quarti, and the base of the tent is called the rhomboid fossa. I'm going to talk more about the rhomboid fossa later in this video, but now let's focus on the structures of the fourth ventricle. So the upper part of the roof is called the superior medullary velum, which is a thin layer of
You guys can't see the video. You can't see the video. Okay, okay. But you're hearing the audio. And she was the one. Where can you? You are the umpire now. Or yeah, can you?
Inferior roof of the fourth ventricle is gonna have this structure right here, and it's also gonna have the coronoid plexus. The coronoid plexus is gonna produce the cerebrospinal fluid, and this one is protected by a layer called the lamina coronoidea epithelialis. Now, so remember, this is just a sketch of the structures, just to give you a little idea of how the structures are situated in the fourth ventricle. In real life, it's a little more complex than that. Alright, and so we have pia mater, and on the outside here we have the arachnoid mater. Remember, the arachnoid mater and then dura mater outside. Just to give you the complete picture, let's go ahead and add it on the other side as well. Here you see the arachnoid mater and the pia mater right here on the other side. So the space between the arachnoid mater and the pia mater is called the subarachnoid space that contains the cerebrospinal fluid, in case you already knew that. So what the coronoid plexus is going to do is that it's going to produce the cerebrospinal fluid and send it through this aperture right here, the median aperture, and it's going to send it to the subarachnoid space and also going to send it down your central canal right here. So that is one aperture, but we have two more apertures or opening in the fourth ventricle, and that's the lateral apertures. Here I try to draw the lateral ones, but if you imagine, if you look at it from the anterior view, this is how it's going to look like. Those are the lateral apertures. And so if you're wondering what's up there, if you continue that canal up there, that canal is called the aqueduct of the midbrain. All right, this is the aqueduct. And if you follow the aqueduct, you're gonna end up in the third ventricle. So that is the structures I wanted to talk about in the fourth ventricle. Now let's go ahead and start with the rhomboid fossa right here. So if you look at, remove the cerebellum and some of the pedicles and look at it from this perspective, you're gonna see that it looks like this. So the rhomboid fossa, let's say with me here, the rhomboid fossa is bordered by the pedicles. It's bordered by the superior pedicle, the medius pedicle, and the inferior pedicle. And now if you look at the internal structures of the rhomboid fossa, you're going to find a sulcus. The sulcus is going to divide the rhomboid fossa into two symmetrical halves. So everything you find in this half, you're going to find it in this half as well, and the opposite. And the rhomboid fossa is crossed by some fibers, those myelinated fibers called the stria medullaris ventriculi quarti, which separates the rhomboid fossa into the medullary part and the part that belongs to pons. So if you look on either side of sulcus medius, you're going to find some elevation, and that elevation is the eminentia medullaris. And eminentia medullaris is going to have some swelling, elongated swelling.
Okay, guys. I think we've hit the point of the video. Okay, so floor of the fourth ventricle, except all the answers are correct except A. So A should be the answer. Hypoglossal nerve is medial to the vagal nucleus. I've discussed this question before and I told you guys the answer. discussed this question before. I was like, hypoglossal nerve is nerve 12. There's no way it will be medial to the vagal nucleus. That's vagus nerve is nerve 10, right? So the nucleus of hypoglossal nerve should be inferior to the vagal nucleus if you understand the arrangement of the cranial nerves. So that's how you can figure out. So every other thing there, striatum medullaris contains auditory fibers. That's correct. Superior medullary velum forms the upper border. That's correct. Facial colliculus is formed by facial nucleus. That's correct. Damage of the fourth ventricle may lead to death of the vital structures located within. That's also correct. So A is the answer, Alex. Alex Ame is correct. Hope you guys can hear me. All right, we proceed. Sounds like something that should be from it. I think I've checked it out before. All right. The facial colliculus is an elevated area located on the pontine tegmentum in the floor of the fourth ventricle. It is formed by fibers from the facial motor nucleus of the facial nerve, cranial nerve 7, as they loop over the abducens nucleus. That's the first thing I even saw from Google. So, are we correct or are we not correct? Stop confusing yourself. It is formed by the facial nerve. Facial nerve is there. So if you saw this answer and you know that there's one that is obviously wrong, you go and choose this one. Abba. Sometimes when you know something too much, it may make you fail a question. Like you over reason it, you overthink it. So I don't think it's that deep. You get and there's obviously a very wrong answer there. So I think we should go with A. All right. Next question. Okay. The next question is about. Let me. Okay, so here's the question. Here's the question. So concerning heart sounds, except first heart sound is due to closure of mitral and tricuspid valves. B. P2 is widely split and fixed in ASD, atrial septal defect. C. First heart sound is loud in mitral stenosis. D. Second heart sound is absent in systemic hypertension. E. Second heart sound is widely split in complete right bundle branch block. Okay. Awaiting your attempt. Okay, for those who joined me the other time, I actually took time to talk about this, and I expect you to get it. We talked about the 4 different kinds of heart sounds, and this one seems to be focusing a lot on the S2 and E splitting, you know, especially during inspiration. So physiological splitting occurs during inspiration. So because when you breathe in, there is an increase now or a fall? When you breathe in, pressure, which eventually leads to increased venous return. And because of that increased venous return, there's likely to be a reduction or a slowing. There will now be, it will now make the to close before P2. That's why you have that physiological splitting during inspiration. And the way you can differentiate A2P2, that's splitting of the second heart sound, from S3, that's the third heart sound, is the third heart sound is usually low pitched, very low pitched. Unlike these ones we are talking about now, this splitting, it will still be high pitched than S3. So let me see if I can find something for you guys for illustrative purposes. See if we can do something. I'll just try and put something very short, like straight to the point. No hula baloo. All right.
This video talks about heart sounds and splitting of heart sounds. So in a heart, whenever we hear a sound, it's because a valve is closing. It's like doors closing. Every time you close a door, you should hear valves closing. But that's only in a normal heart. In a pathological heart, we hear sounds which is not related to only valves closing. But let's focus on a normal heart for now. So let's say this video talks about heart sounds and splitting of heart sounds. So in a heart, whenever we hear a sound, it's because a valve is closing. It's like doors closing. Every time you close a door, you should hear valves closing. But that's only in a normal heart. In a pathological heart, we hear sounds which is not related to only valves closing. But let's focus on a normal heart for now. So let's say when your tricuspid closes, you should hear a sound. When your bicuspid closes, you should hear a sound. When your aorta closes, you should hear a sound. And when your pulmonary closes, you should hear a sound, right? So I can say that S1 is a combination sound of the tricuspid and pulmonary, and S2 is a combination of sound between aortic and pulmonary. Not between, like the timing of aortic and pulmonary is S2, and the timing of tricuspid and mitral closing is going to be S1. So those are the sounds, right, when they close together. Now what happens is, what's interesting here is, aortic and pulmonary don't really close at the same time. There's a really tiny gap between the two, and in a normal heart we usually don't see it because the timing is so close. But in a pathological state, or in other situations where you're exacerbating a situation where they cannot close at the same time, you actually hear the difference. You know, they're closing at different times. You actually hear it, and that's what we really call split, right? Okay, so S1 is really a combination of mitral and tricuspid closing, right? And S2 is really aortic and pulmonary closing, right? So our focus is really S2, not S1. So we're just going to treat S1 as S1. S2, we have divided this into A2 and P2 here. Okay, so now let's say this is a normal heart, and let's say this is your S1 sound, this is your A2 sound, and this is your P2 sound. By the way, x-axis, treat it as a timeline. You know, that means the difference between S1 and S2, the time is this much. The difference between A2 and P2 and time is this much. This is in a normal heart when you're expiring. But let's say you are inspiring. By the way, why does pulmonary close after aorta? Pulmonary close after aorta because the pressure in the aorta is much higher than the pulmonary. So the tendency of valves closing before pulmonary is going to be higher. So that's why aorta closes before pulmonary. But this situation can be reversed if the pressure in the pulmonary is going to be higher. You can see that, right? That the situation can be reversed. But we're not talking about that now. We're talking about what we're going to see in a normal patient during inspiration. So during inspiration, what you're doing is you are filling your heart with blood. So as you're filling your heart with blood, okay, you know, I mean, blood is pooling onto the right side of the heart, right ventricle, okay, and because of inspiration, this is you know, because the lungs needs more blood flow, the lung is creating a vacuum, right, which is causing the right side of the heart filling in more than a normal situation. So I'm talking about inspiration when you take a deeper breath for inspiring, okay. So so what happens is the pulmonary valves cannot really close, right? The pulmonary valves really cannot close until the blood flow to the lung is finished. So compared to an inspiration, the pulmonary valves is going to close later because the door is open longer, right? Imagine that this is the door, and since the lung is creating a vacuum while the blood is flowing through the pulmonary to the lungs, so since the door is open longer, P2 is going to go on for a longer amount of time, right? As a result, what we're going to hear is S1 is going to be at the same time. A2 we are going to be hearing at the same time as well, but P2 is going to be much further down the timeline. So the distance between A2 and P2 has really increased, and this is increased because of inspiration. So this kind of situation where due to inspiration your P2 is closing at a later time, you are creating a gap which is now audible. You can actually hear the split. So that's when you hear a split. So now we can say that inspiration is really causing the difference in the split, and we can actually hear the splitting, the heart splitting during a normal inspiration. So this is a normal state. It should not happen all the time. You should only hear it when you're taking deep breaths. can only should hear the split when you're taking deep breaths. If you're hearing in a normal time, that is pathological and that is not normal. You should not hear it in normal heart sounds, in a normal breathing pattern. So now let's talk about wide split. What does wide split really mean? So again, we're dealing with S1 here. Okay, S1 is going to be here. Let's say A2 was here. And in a normal state, let's say P2 is here. And obviously we're talking about expiration P2. Let's say this was normal. Okay, what's going to happen with wide split is that the P2 is going to move in here further from the normal one. P2 is going to move. Okay, and this is going to happen in an inspiration as well. So S1 is going to be in the same position, A2 is going to be in the same position, P2 is going to be even further. So yes, it is wide split, but the expiration and the inspiration will have a longer split than the expiration, but even expiration is going to have a longer time lapse. Okay, so this is a wide split. So why should we have a wide split? We have a wide split for two different situations. Either it's a pulmonary stenosis, okay? Pulmonary stenosis can cause wide split. And we also hear wide split in right bundle branch block. That is classic for wide split, okay? So what happens is in right bundle branch block, the heart is not completely functional on the right side and they're not getting the impulse as faster as the left side. As a result, there is going to be slower closing of the pulmonic valve, causing the wide split. Now the next thing I want to talk about is fixed split. See, I wanted to talk about wide split before I talk about fixed split is because see how this changes with inspiration and expiration. That's why this is not fixed split. If this was constantly both inspiration and expiration was the same spot, like so, then we would have called it fixed split. So let's look at it. So again, let's draw the normal. We have S1 here for inspiration. We have A2 here for inspiration and expiration. And let's say the normal should have been like that. Okay, let's say the normal of inspiration and expiration, but instead we are having like so. See, the distance between the A2 and the P2 is the same as inspiration and in expiration. So this kind of state is the fixed split. So when do we see fixed split? We see fixed split when we are talking about ASD. And why is that? Because there is a constant amount of blood flow coming from the left side to the heart side, the same amount every time, and the factors that is affecting the the left atrium is also affecting the right atrium. So if there is a change in inspiration, that will also affect the left atrium because they're directly connected. If pulmonary wants more oxygen, more blood is going to come from the left to the right side. So factors that affect. But even then, now you might be asking me, then why isn't, if the pressure is kind of equalizing, then why aortic and the pulmonary is not closing at the same time? I want to correct you in your thought that the pressure is not equalizing. It's just that the factors affecting the left side of the heart and the factor affecting the right side of the heart is kind of compensated equally at the same time. There is no time lag because of that little doorway that has been made. So last of all, I want to talk about paradoxical split. So whenever we...
Okay guys, I believe we've gotten what we are looking for in that lecture. So you said the answer was someone chose A. He said second heart sound is widely split in complete right bundle branch block. We are looking for the exceptor, so you are just picking one of the correct answers. Then Alex Ahmed chose A. Said first heart sound is due to closure of mitral and tricuspid valve. Yes, it's correct now. Then someone chose D. How is B and D appearing wrong? P2 is widely split and fixed. S2, that's supposed to be S2. S2 is widely split and fixed in ASD. Widely split and fixed. You just saw it now that it's fixed. Fixed splitting. That was the last thing she was demonstrating in the video. That is widely split and fixed. She just demonstrated it now because she showed you that even the normal was shorter than the one of ASD. It's wide and it's fixed. So it's correct. But that's supposed to be S2, not P2. Then D is the answer. Second half sound is not absent in systemic hypertension. In fact, second half sound should be A2 in particular, should be louder in systemic hypertension, just like P2 should be louder in that question. Any confusion again on heart sounds? Is there any question on heart sounds? So that once you see any question on heart sound, you know you're scoring it. All right. I'll go to the next. So this next question is about is from biochemistry. Is testing your knowledge of enzymes, okay, and enzymopathies and their relationship to a certain blood cell. All right. So here's the quiz coming up in a sec. Here it is. So the question says the following are enzymopathies that may cause a decrease in red cell reducing power except A. Hexokinase deficiency, B. Gamma glutamyl, C. Glutathione peroxidase, E. Glutathione synthase deficiency. Still awaiting more answers from others. Alex Arme has answered, has attempted. Chima has attempted. Okay, waiting for more.
So whenever we say paradoxical, it means that
Awaiting your answers. Beatings. All right. Why? Because it's one of the cells, or is even the only cell in the body that doesn't have nucleus generates. Once anything, once you, that's why it has a lot of enzymes that naturally follow it about, that helps it to carry out its function, and also helps it to maintain uh, sort of equilibrium, you know, so to ensure that um, kinase deficient, those kinase pathway, especially talking about is an enzyme that is involved in uh, glycolysis, right? Yeah, I think it's the rate limiting step in glycolysis, in the glycolytic pathway. So, and you know that red blood cells use a lot of the glycolytic pathway, because not just that they don't have nucleus, they don't have mitochondria. So they depend only on that glycolysis for generation of energy. They don't have mitochondria where they can use up other sources. They can do all this oxidation to produce higher energies. So they can't run the citric acid cycle, which only occurs in the mitochondria. So they have to depend only on cytoplasm, which is where the glycolytic pathway occurs. And hexokinase is the enzyme that is involved, okay? The rate limiting step in glycolysis. Then gamma glutamyl cysteine transferase. Gamma glutamyl transferase. What is it even involved in again? Like GGT. I can't remember, but I know it has something to do with liver. Liver. Gamma glutamyl transferase. Yeah, it's involved in liver. I think it's involved in metabolism of bilirubin and all that. That's why we test for it during liver disease and obstructive jaundice. Remember, we mentioned it extensively yesterday. Then glutathione peroxidase. In fact, both glutathione peroxidase and glutathione synthetase, they are both involved in glutathione synthesis. And you know that glutathione is like is an antioxidant. That's essentially what it is. So it mops up tissues and cells, mops up oxidative stress, toxic reactive oxygen species, which are detrimental to the health of cells, especially the red blood cell, which does not have nucleus that cannot regenerate. Then G6PD, remember your glucose 6-phosphate dehydrogenase, right? Which pathway is it involved in, and what is the importance? I think is involved is its importance is related to the generation of is it pentose phosphate, PPP, pentose phosphate pathway, glucose phosphate dehydrogenase. So still has something to do with oxidative stress and all that. Anyway, so I think you guys are correct, because that GGT is involved in liver disease. So I'll move on to the next question. This one tough. It's simple though. I think it should be in one of their materials. But I couldn't really lay my hands on it. It's simple, but if you don't know it, it will look tough. It's very straightforward. It says the following drugs are largely excreted thereby. Now, so we see the question. So, make una answer. Me too, I want to learn it because I didn't see it. So which of the following is largely excreted thereby? Is it all of? Is it just one of them? Is it some of them? Is there an except? Is there any one of them that cannot be excreted through bile? Okay. Are you sure when you are giving us any answer? Be sure, because injury time. Okay. Just want to know is there any chance that we can find something related to that? Roads of drug excretion. Okay. Pharmacokinetics. Let's see whether we can find something. Pharmacokinetics. Remember your pharmacodynamics is what um, drugs does to the body, right? The pharmacokinetics is what the body does to the drug. So Have I been talking to myself all this? Why? It seems so. Okay, so here's the question coming up. Hope you guys can hear me now. Um, Here is the question. Okay, great. Okay, so it's coming up here. And go. I'm still looking for the answer. I'm still looking for the answer. That's why I said if any of you know it, that you can educate us. I mean, if I was looking for the answer. Okay, but I think it may be related to lipid soluble drugs. I think that may be a way for us to know. But I'm still looking for it. If I find it, I will let you know. Okay, I think I just found a resource that may be useful to us. Anyway, but still no more attempts. No idea. So with regards to cell cycle and death, cyclin-dependent kinase regulate the progression of the cell cycle. Transient arrest of the cell cycle at G1 checkpoint is associated with increased chance of malignancy. The process of differentiation allows the cell to withdraw from the cycle. Apoptosis usually occurs when cells are in G1/S phase. Apoptotic cells discharge damaging enzymatic content to the exterior. Okay, so what are we looking for now? We're looking for the correct one, right? So let me start from the bottom. Apoptotic cells discharge damaging enzymatic contents to the exterior. That's false. Apoptotic cells do not do that. That's why apoptosis is one of the differences between apoptosis and necrosis. Because during apoptosis is like cellular suicide, and it follows they call it programmed cell death. So it follows a very well programmed pattern in such a way that at the end there will be no inflammation. It will just divide all the organelles, all the contents of the cell into tiny pieces called apoptotic bodies. These bodies are still like the cell. They are just like tinier portions of the cell. So they do not stimulate inflammatory response. So that's why apoptosis is better than necrosis, because unlike necrosis, where you start having stimulation of the inflammatory cells, because necrosis releases enzyme. Even autolysis is even worse, because that one will just break down the cells and with enzymes and stimulate so much inflammation. Then apoptosis usually occur when the cells are in G1S phase. G1 uh, G1 is gap one, while S phase is the synthesis phase. When is apoptosis likely to occur? I think is G2. You know, I think it's G2 stroke mitotic phase. So let's check that out. Then the process of differentiation allows the cell to withdraw from the cycle. That's not the function of differentiation. Uh, process of differentiation allows the cell to withdraw. That's not how it works. Then transient arrest of the cycle in G1 checkpoint is associated with increased chance of malignancy. Even arrest should prevent malignancy, not the other way around, because in G1 there are checkpoints between G1 and S phase. There's G1, there's S phase, there's G2, there's N, which is mitotic phase. So within all these checkpoints, he's just trying to prevent cellular mutated cells or cellular damaged cells that are damaged to move into the next cycle. So it's actually supposed to prevent malignancy. Then cell dependent kinase regulate the progression of the cell cycle. Yes, cyclin dependent kinases, CDK, regulate the progression of the cell cycle. That's very correct. So the answer is A. Then for the other previous question, let's see whether if we look at this resource, whether we can find something. Let's look at it together.
हेलो फ्रेंड, वेलकम टू चैनल सॉल्यूशन। आज के वीडियो में हम डिस्कस करने वाले हैं रूट ऑफ ड्रग एलिमिनेशन के बारे में, शॉर्ट में और पॉइंट वाइज डिस्कशन। इससे पहले हमने रूट ऑफ ड्रग एडमिनिस्ट्रेशन के ऊपर भी वीडियो अपलोड किया है। अगर आप रूट ऑफ ड्रग एडमिनिस्ट्रेशन के बारे में जानना चाहते हैं तो हमारे दिए गए डिस्क्रिप्शन लिंक में जाकर के रूट ऑफ ड्रग एडमिनिस्ट्रेशन के बारे में वीडियो देख सकते हैं। इससे पहले कि हम आगे कॉन्सेप्ट की ओर बढ़ें, आइए कुछ टर्म्स के बारे में जान लेते हैं। हमें 3 टर्म्स को समझना जरूरी होगा आगे के रूट ऑफ ड्रग एलिमिनेशन को समझने के लिए, जिसका पहला वर्ड है फार्माकोलॉजी। फार्माकोलॉजी मतलब होता है इट इज अ कंप्लीट स्टडी ऑफ द इफेक्ट गिवन बाय ड्रग एंड रिस्पॉन्स गिवन बाय बॉडी टूवर्ड्स द ड्रग। यानी कि फार्माकोलॉजी में हम ड्रग बॉडी के साथ क्या करता है और बॉडी उस ड्रग के रिस्पॉन्स के साथ क्या करता है, इसकी स्टडी को हम फार्माकोलॉजी कहते हैं। यानी कि इसे अगर हम फार्माकोलॉजी के लैंग्वेज में बात करें तो फार्माकोलॉजी मतलब होता है फार्माकोकाइनेटिक एज वेल एज फार्माकोडायनेमिक स्टडी ऑफ ड्रग। फार्माकोकाइनेटिक मतलब होता है व्हाट डज बॉडी डू टू द ड्रग, यानी बॉडी ड्रग के साथ क्या करती है। जनरली बॉडी ड्रग के साथ। हेलो फ्रेंड, वेलकम टू चैनल सॉल्यूशन। आज के वीडियो में हम डिस्कस करने वाले हैं रूट ऑफ ड्रग एलिमिनेशन के बारे में, शॉर्ट में और पॉइंट वाइज डिस्कशन। इससे पहले हमने रूट ऑफ ड्रग एडमिनिस्ट्रेशन के ऊपर भी वीडियो अपलोड किया है। अगर
Okay, now except any of you here that have or have to end it there. See. Oh, they even indicated that is in Hindi. Anyway, so I think I'll just write down. I'll just write down in the class. Maybe if I look for it later and I find something, I will still get back to you on that. I'll write down. But I think in the video they actually put in some drugs. There is a text there. Route of drug elimination, urine to sperm. Okay, let me just write down. After I'll sort down. This one is going back to genetics. Okay, that's taking us to genetics. So attempt the question. It says the following statements are true about DNA. Okay, so recombinant DNA technology. Attempt the question. Attempt the question. fine now. This question is simple. It's aorta. It's aorta, you're correct. You're correct. Okay, so I think we should just write down. Still can't find any concrete stuff. The next question is still biochemistry. Okay.